how hard you run your body is going to give you that sort of health span. And that's the new term. There's a dial, and I want you to think about turning the dial one way, and it's like, I'm inflamed, and turning it down to the other way, which says, I'm doing nothing, or turning it to optimal, which the immune system goes, I can handle both, but I'm not off. If you are inflamed, your body goes, nope, guess what? We're under stress, protect the host. The idea that a drug only has one function, one receptor site, it's so antiquated now.
Welcome to The Trusted Pharmacist, where you'll learn the truth about how the body works.
Welcome back. I'm Steve Hoffart, the Trusted Pharmacist, and I'm excited to have my special guest, Sebastian Denison, on today's show. Sebastian is not just an outstanding pharmacist, but he's also my close friend and mentor. Sebastian comes from a family of scientists, doctors, and nurses that have always been committed to helping others, and I think that's where Sebastian got his giving spirit to want to help others. And it isn't so much just helping on the health side, it's helping the community as a large get and feeling better in the long term. And I can tell you, as my friendship with Sebastian has been, Sebastian is on my hotline. Many of you are like, Steve, you're so smart and you know so much, but I get asked questions all the time that I can't answer. And guess who's on my hotline, on my phone? And that's Sebastian. We have worked together to work on some super challenging patients that nobody else could fix. And through his excellence and his knowledge of pharmacy and wellness, we have been able to solve some master complicated patients, and it's all because of his knowledge and working together. So first of all, we are so lucky to have him here. Sebastian, so great to have you. How are you doing today, buddy?
Well, I'm completely flattered and impressed with that sort of discussion, and completely humbled by the fact that I'm on your hotline, because I know what an amazing team you have and what an amazing group of friends you have. So for me to be part of that collective, I'm just thoroughly thrilled to be part. So thank you.
No, man, don't feel that way at all. No, so glad to have you. So just as a start, Sebastian, you work at PCCA, which is one of the companies that we use to get all of our quality ingredients for our compounding, but also education for myself and my staff. Tell the average audience what you as a clinical pharmacist does at PCCA.
So PCCA is a really unique company in that we supply all of the intellectual property formulas, but we also sell chemicals and bases to compounding pharmacies. Specifically, we don't work with large scale chains or these conglomerates. We stick to the independents because we want to focus in on making sure that we have the highest quality outcomes for the patients at the end of the day. And that can get lost in the sort of mass marketing, mass efforts. So PCCA is a unique privately held company that has been focused solely on independent pharmacies since their inception over 45 years ago. And they developed a team of specialists, clinical pharmacists, that could help troubleshoot other pharmacies, because no single person can know everything. So to have people with different experiences who can talk it through and literally be on that hotline and be like, hey, I need help. I'm the guy on the other end of the phone, because after doing this for a number of years in a compounding pharmacy in Canada, they said, did you want to join our team? And I was absolutely thrilled to become part of this collective of clinical pharmacists that answer questions from other pharmacies from all over the US and Canada. We've got memberships through Australia, New Zealand, into Europe, and now with Southeast Asia. So we're taking calls from all over the world and trying to help solve problems. Now, to be clear, I don't know everything either. I happen to work on an amazing team. There's 20 of us who are on my team. We're spread throughout the US. And actually in Canada, we had some offices up there, and we are doing our best to stay current with what's happening in health and pharmacy, current paradigms of treatment, and all the new drugs that are coming out. So that's effectively my job, is to keep learning and to keep helping and to take phone calls and help others learn quickly. So there you go.
Well, that's why you're here today, because you have a unique perspective. I will say some people are addicted to food. Some people are addicted to drugs. Some people are addicted to alcohol. I can tell you, me and Sebastian, we're addicted to knowledge and education and doing research, because I think that's where we've learned the health trends are going, is trying to take a deep dive into studies, clinical knowledge, and find the truth about how the body works. And I can tell you, if I can only imagine, he digs different than me, and he's like my go-to on that. But that's what gives you a unique perspective. Not only are you a pharmacist, but you're very well respected, but you're very knowledgeable. So let's kind of start with this. Tell me right now, Sebastian, we were talking before we got started. Tell me kind of where you think like the healthcare system's kind of messed up right now. You and I went to pharmacy school. it's one drug for one condition, and this is just the way it is. And we don't look at everything as a whole. We just look at that drug. Tell me where, you speaking internationally to doctors, to prescribers, to pharmacists, to patients, you got a unique perspective. Tell me kind of how you see where the health system's kind of off the rails, or where it's broken right now.
So this is actually a really big conversation that a lot of people are examining, and everyone's got their ideas, and they think it's the payers, they think it's the insurance companies, they think that there's, there's this ennui of like overthinking, and we got lost somewhere along the way, where we've given so much over to this idea that if you are sick only in this single silo. And so people will say, you have arthritis in your elbow, for example, and that was the example I used, and everyone will focus in on treating the elbow and treating it with a specific drug for that specific condition of the best for elbows. But what we fail to understand is that there must be something going wrong in this system for the elbow to become diseased. And generally, we're starting to see this bigger trend more recently where people are starting to say, we can't silo out medicine. We have to look at the system. We have to look at the patient as a whole and fix the underlying patient problem before we can adequately address this single issue. Now, functional medicine, they always talk about fixing the gut, and everyone focuses in on the gut, and they say your gut is your source of health. And I cannot disagree at all, because this is truth. But what we also see centered in your gut is your entire immune system. Functionally, that's where it predominantly will operate and then move out from. And so if you have a dysfunctional gut, you have high potential for having a dysfunctional immune system. And honestly, if you have a dysfunctional immune system, it is just a really true question of how much time before you start to see those conditions really come to the forefront. And since 2019, arguably, there's been this huge movement to where they say dysfunctional immune system leads to pretty much every chronic health disease issue you're going to face in your lifetime, including all cancers, all chronic diseases, all cardiovascular diseases, everything that ails you as you age. And we see it moving into a younger and younger population. Patients who are sick at a young age, we can point to the immune system and say, here's your issue. Get it under control, and we will have a better outcome for you long term. And so finally, that's catching up. And then the second part, and this is like, I will try not to get on too high of a soapbox. People understand that, and I'm not going to get into this discussion about like big pharma and stuff, but people will focus in on this idea that, one medicine, one cure, but there's also this idea of like, hey, we have a really good medicine. Let's find a use for it. And so it's something called Selling Sickness. It was a really good book. I read that back when I was a young pharmacist. That was in the mid 2000s, where they will start talking about a problem and everyone gets excited about the problem. Then they say, and by the way, look at our cure. And unfortunately, it's really spendy and very, very expensive. And that's where people are doing the selling of sickness and this idea that the only option is this drug. And so we want to move away from this idea that there's only one cure to these issues. When we start looking back at the system, maybe we can see patterns of dysfunction where we can address those earlier and earlier, maybe pull people away from that severity of disease. And I'm not saying anything I'm going to talk about is a cure by any stretch. But what we're going to say is you and I, Steve, we've had so many conversations about, well, what's the pattern? And it goes across things from pain to rheumatoid arthritis to autoimmune diseases to obesity even. You can see these patterns of dysfunctional immune system activation. Once you see the pattern, you can't unsee it. And then once you hear people coming along and be like, I have the magic bullet, it's kind of like, well, hang on. We don't want to overstate. And that's what we're also getting into is like, we have to be realistic in our expectations and the outcomes for these patients.
You just put a lot in there, and I'm going to try to unpack a couple of things you just said, because that's just the way you operate. So first of all, this immune system, you and I think immune system, oh, that's what I need to fight off the flu. Okay. But it's that same immune system that is just sitting there always trying to protect us from the outside environment. The problem is, like you said, we've challenged it in a way. And I don't think people even realize, people probably would understand like autoimmune conditions is a dysfunctional immune system. That's pretty common, right? The immune system attacks something the body shouldn't. But I don't think people realize a dysfunctional immune system causes cardiovascular disease. A dysfunctional immune system causes Alzheimer's disease. A dysfunctional immune system causes all these diseases, but I don't think sometimes people think of it like that. And you're right. It's like it kind of all goes back to that. The other thing I think is important that you mentioned is about taking the systems approach. And you can't, it's not one drug, one cure. Because like you said, there are so many drugs that's like, oh my gosh, you got psoriasis. Let's take XYZ drug that will shut your immune system off. But then, hey, you just cut off something that's supposed to protect a lot of other stuff. We better be careful. And then you're right. We talk about this all the time with the clinical consultants at PCCA. They'll always recommend a compound, but they're always like, hey, don't forget about sleep. Don't forget about stress. Don't forget about diet. Don't forget about all of these other things that also have an impact, like you said, in the silos. Now, dysfunctional immune system is one thing, but what do you think's the big driver that you and I talk about all the time that makes that makes the immune system dysfunctional? What is that ongoing process in our body that drives this immune system to get dysfunctional and drive all these diseases? What do you think that number one thing is we talk about all the time is?
Well, I've already alluded to the first one was a dysfunctional gut. An unhealthy gut microbiome is one of the major drivers. This we've known from functional medicine for years, and people get they kind of can't wrap their head around it. Is that you need to actually have healthy gut bacteria, and you need to have a high microbiome biodiversity. Without that, it's really hard to establish a healthy pattern of function in your gut. And that can lead to dysfunctional, so they call it hyperpermeable gut dysfunction. And so what happens is that you can reabsorb larger molecules. You have this improper nutrient absorption. You can actually have an inflammatory response in your entire GI tract, which is really, really long in respect to the length of your body. So what happens is that you can drive a lot of inflammation just through a dysfunctional gut.
You've said it twice now. What's that magic word?
Inflammation.
Inflammation. That's exactly right as far as that goes.
And then these are some other ones that people don't quite wrap their heads around, but people don't realize the importance of sleep. I think it's within 3 to 5 days of or incomplete sleeps, non-restorative sleeps, you could actually start seeing a driver of inflammation. You can see all the inflammatory cytokines kick up. And it's literally this cocktail that just kind of goes, whoosh, inflammation. You have to protect the body because you're not restoring properly. And then extremes. And now that's going to be a weird one where it's kind of like, what do you mean extremes? Extreme dieting, extreme exercise, extreme lifestyle, extreme living. What that does is that actually stresses the body in different ways. So I've got a friend, he's into marathons and running too much, chronically injured, and he can't figure out why he's always sore. And then he starts seeing this degradation in his actual running ability because he's injured all the time, and he complains about it. And he's like, yeah, my shoulders hurt, my back hurts, I get headaches all the time, my heart is just not running. Like, you're inflamed, you got to back down, because he's at an extreme of one thing. Extreme dieting, like I'm going to restrict all my calories because that's going to help me lose weight. And your body goes, oh, we're in a famine state, therefore, or famine, Canadian, again. And so all of a sudden it goes, protect the host. We have to ward off, and we're expecting a stressful time. People who have this extreme lifestyle where they're, drinking and partying and going really hard, man, you can see this aging against their body. And it's really their immune system that is really taking the hit, because your immune system isn't there just to ward off all pathogens and protect the system. It's also designed to help repair and initiate repair cascades. You have to have a functional immune system to actually functionally continue in a healthy pattern, not just for the anti-infective or anti-pathogenic reasons, but repair. And so that is normalizing function. Your brain is awash in these, your immune system, helping support normalized function. If you're highly inflamed, as you mentioned, dementia, Alzheimer's, neurodegeneration, the aging brain. In the lungs, you can actually have aging lungs. COPD is an exacerbation, but it's pulmonary fibrosis. In your cardiovascular system, the aging heart, you can actually see atherosclerosis. If you are dysfunctional, you will see the degradation of the system over time. That's how hard you run your body is going to give you that sort of health span. And that's the new term. So I'm hoping to add this to everyone's lexicon from this podcast is health span, inflammaging, and chronic stressors. So there you go.
Yeah. And you, like you mentioned, I think you've said the word about 15, 16 times is inflammation. We all know that is the driver of disease. And we were talking about that. And I think if we look at is inflammation or by calming inflammation, this is what starts to set us up for success in terms of reversing it or calming that down. I think we all live with some just standard inflammation. It's part of the body's process. We need to, but when it becomes excessive or beyond control, the immune system gets dysfunctional and it causes problems. And many of the compounded options, we're going to talk about things that control control disease are basically by modulating this immune response or this inflammation response. So what are your thoughts on that?
Modulate, not suppress. Suppressing is actually really bad. I'm going to drag everyone back to the mid 1980s, where we saw the rise of HIV. And HIV is an immunodeficiency virus where you could actually suppress the immune system function. And you see this whole bouillabaisse of really nasty outcomes for these patients long term. And so you go from HIV to a full-blown AIDS, and that collapses the immune system. That's what happens when you turn it off. It is not good for the long-term health of the patient. And so we really have worked so hard since the onset of HIV to understand how that immune system is so complex and also work within the parameters of making sure it is a robust, healthy response as opposed to a full immunosuppression. Generally, when we do that in the hospital, we have isolation, or when we're giving these drugs, we're telling people like, if you spike a fever, it's life-threatening. So we have to be cautious with using these really strong anti-inflammatory or immunosuppressant drugs because the consequences are pretty big. Whereas you made the comment, immunomodulatory versus immunosuppressant, we actually can pull away from dysfunctional inflammation as opposed to healthy inflammation and get people back onto the track of a healthy path. So there you go.
So Sebastian, you came to my pharmacy and spoke for my medical providers about 10 years ago about something called low-dose Naltrexone.
Oh, man. Yeah.
I didn't know what it was. I think we had 3 or 4 patients on it. Fast forward, we probably have filled this for 10, 15,000 patients. And as far as a immunomodulatory drug, to me, it is the classic example of repurposing a drug at a lower dose to get benefit, i.e., like you just mentioned, this drug was originally developed to help patients who had to tank the immune system with HIV and actually help to bring their immune system back to help them survive back when we didn't have HIV drugs, to the point now we're using the same exact drug that can actually stimulate the immune system, can then boost or can calm the immune system in terms of autoimmune conditions. So super quickly, not getting too deep, LDN. Tell me a little bit about how LDN really is this wonder drug in terms of modulating that immune system to help with many of the chronic health conditions we're seeing nowadays.
I'm going to do my best not to be too dorky, but yes, 1993, Dr. Bahari, he recognized that there was this change in HIV positive patients, and we actually saw this endorphin change, but we also saw this change in their immune system function. And people didn't understand how it did it. Fast forward to 2015, 2014, we started seeing the first papers come out and that talked about where naltrexone fit into this receptor family that was actually the kickoff of inflammation across your entire immune system, from your microglia up in your brain through out to the periphery and through your entire gastrointestinal tract. And so these, how naltrexone works is it would have this short pattern interrupt, and it would settle down this receptor from sending a signal of danger or pathogens. And so there was damage-associated molecular patterns and pathogenic-associated molecular patterns that naltrexone looks like, just enough that it fits in the receptor, but is different enough that it doesn't activate the signal. It turns it to a normal signal. So that's the thing. There's a dial, and I want you to think about turning the dial one way, and it's like, I'm inflamed, and turning it down to the other way, which says, I'm doing nothing, or turning it to optimal, which the immune system goes, I can handle both, but I'm not off, and I'm not overstimulated. So naltrexone really helps reset the dial to a normal function of the immune system without suppression, which is crucial.
No, and that's a great explanation. And like he said, and like we were talking previously, these biologics nowadays that are for all of these autoimmune conditions, it just slams the immune system one way. And unfortunately, when it is slammed shut, you can't fight infection, you can't prevent cancers. So that's all the nasty side effects where LDN or low-dose naltrexone provides that modulation in the middle, but it's at these low doses. You know, that drug was originally developed, like you said, for alcohol addiction and drug addiction and things like that at hundreds of milligrams, where we're talking most patients, I think you would agree, 3 to 5 milligrams fall in there. I mean, as far as that goes, what are the current trends with LDN or low-dose naltrexone that you're seeing?
So we've been talking about this for a number of years, you and I. I think you are one of the people, because we've been doing this for 10 years, you were one of the ones who really turned this into a bigger discussion for so many patients, certainly up in Magnolia, but down here in Houston, foundationally, we've had so many providers asking the questions. The LDN Research Trust, they're a charity organization, and they've got collectives of leaders in thought, especially around LDN. And we've seen this trend of lower and lower doses, especially lower initiation doses, and this smaller step towards titration for this understanding that we have a very crucial sweet spot for each patient. And when I say each patient, we're talking about a range of 3 to 5 milligrams, but we've seen patients as low as 0.1 milligrams and patients as high as 9 milligrams. But there can't be this aggressive, well, you're going to get X because that's what I read in the literature. It's actually, that's a very fuzzy target, and each patient has to be dialed in. Because, you ready for this one? And for your patient, or for all of the listeners, your podcast listeners, let me be clear. Currently, we are at 18 receptors that naltrexone works in slightly different actions. 7 of which are in the immune system. There's 7 mu receptors, and there's a couple of other new ones, and we've just discovered 2 more in the last year. That we are looking at the functionality of those receptors being very subtle. And so if you give too much, it doesn't work the way you want it to. In fact, it just kind of washes through that receptor system, and then you're turning off functionality. So too much of a good thing becomes a very bad thing with naltrexone. And so the big trend with naltrexone is some is good, very small increments is best. Whereas big steps, you're going to blow past the optimal point for patients. And we saw responders about 50% for years and years. But people who are more subtle, such as yourself, you're seeing closer to an 85-90% responder rate in those patients. And so what we're doing is we're turning off that dysfunction, or we're modulating that dysfunction. So therefore, we're turning off that high signaling of inflammation, and it makes every other intervention work better. If you want to see some real changes, there's multiple studies where we see a decrease in all other medications. All other interventions work better. Extension of functionality for the patient, improved quality of life, improved patient-reported quality metrics. And we're starting to replicate this. It's kind of getting interesting. Dr. Zalzaba is looking at quality of life and health span functionality. We just see more literature. And that's the big part where I'm excited about medicine is because of our technology and because we're understanding the importance of sharing this information, that proliferation, and this is where the turning point of medicine has come now. So again, very positive about this, is people are moving away from this idea of one person has to know everything. It's now turning into, I need to connect with other healthcare professionals who have different insights to treat the patients that I'm looking after. I don't know everything, but I know someone who knows something about this. And that's kind of the good part. So there you go.
No, and LDN is a great example of personalized medicine. There is no better drug because it is so patient specific. I post stuff on social media all the time about low-dose naltrexone and the benefits, and I get this comment all the time. It just didn't work for me. Well, when I hear that, I can't go back and forth on social media with people, but I want to say, where did you start? How fast did you go up? Because odds are your doctor just started you out at some milligram. And like you mentioned, when I did this 10 years ago, it was not uncommon to start people at like 1.5 milligrams and then work up. Now we've got patients at 0.5, 0.25, and even 0.1 that we're working up more slow because you're right. Everybody has that sweet spot dose. And to me, I found is the more inflamed and the more out of control somebody is, the less they tolerate it because they just need a little bit amount to kind of get the body going. And it doesn't take a lot. So to me, it's like one of those things. If you've got chronic inflammation, Even things like weight loss, like we've been using that as a weight loss combination for a long time because, when the body's inflamed, it will not let go of fat. Like it's just going to hang on to it because it's saving it for a rainy day. And so we've just found LDN to be very effective because it also helps control appetite because it works on dopamine. I mean, there's so many, like you said, there's so many things it does. It's crazy.
There's actually recent literature that talks about your visceral fat. Once you have this high, and they call it high food intake, you will actually trigger an inflammatory response for storage purposes because feast, famine, right? It's either way. So if you can eat a lot and it's this overnutrition effect, you will kick off an inflammatory response to actually cause fat accumulation and storage. And you are correct. If you are inflamed, your body goes, nope, guess what? We're under stress, protect the host. And it is so much harder to lose weight if you're like, it's literally metabolically, your body is saying, don't lose it. And it's protecting those fat stores. Whereas if you decrease the inflammation, all of a sudden your body goes, oh, we can let this go. And all of a sudden you can actually see these patients start losing weight with that sort of combination of immunomodulation, decreasing the inflammatory cytokines, changing in food patterns, and also changes in calorie intake. But you can't just go to a straight 0-calorie diet because your body goes, it's an extreme. So you actually have to keep eating. You just have to eat more of the healthy stuff. So anyways, there you go. That was
all about moderation. Let me ask you one thing about LDN. Last thing, I'm getting more and more about hearing people who've taken it and then all of a sudden it's like, oh my gosh, it stopped working. Are you seeing more and more that's recommendation to take a break on occasion now versus just doing it every day all the time? Because it is a super safe drug. It's non-addicting. It's safe. We've got a lot of long-term data, but are you starting to see more and more recommendation maybe to take a break at some point?
We're quite happy for patients to take like a weekend off every couple of months. And so this is actually sort of a built-in sort of do a 3-month supply. And then every 3 months, just take 1 or 2 days off just to allow your body to reset. Some people be like Monday through Saturday and take Sundays off. And in fact, the new paradigm, and this is an important one from the LDN Research Trust in the cancer world, they do a pulsate therapy of Monday through Friday, 2 days off. That's how they're treating you for adjunct care for cancers with LDN is 5 days on, 2 days off all the time. And so I think that that's actually going to become a more standardized plan for people is Monday through Friday, 2 days off. We'll see where this goes, but I'm quite happy with LDN holidays. Your immune system, again, it's a dynamic system. One thing, I think this is where we actually, I'm going back to HIV, is bias therapy leads to bias outcomes. So again, too much of a good thing can become a bad thing. So you have to modulate what you do as well as not be extreme.
Yeah, so you mentioned cancer, and LDN is a great choice because inflammation drives cancer. But one of the hot things we're getting at the pharmacy request right now are these antiparasitic drugs for things like cancer and arthritis. And I do think you and I both know if we've got underlying infections that are constantly tickling that immune system, this can drive inflammation and drive disease. But they're starting to learn that some of these antiparasitics may work a little different, and it isn't all about killing parasites. What are you guys seeing on the clinical side of PCCA about requests about these type of drugs?
So I have to be careful because this is where I can get super dorky. Again, the idea that a drug only has one function, one receptor site, it's so antiquated now. Naltrexone, we've got 18 receptors that it fits in. Some of these antiparasitic drugs, they're now talking about and this is the classification that they will touch 9 different mechanisms of function in living cells. So this isn't just parasites. It's not just an antiparasitic drug. It is a living cell drug. And so you're hijacking different functions in those cells. And how we're fighting parasites is because they have a different metabolic rate. Once we apply this into cancers and we're using the same drugs at slightly lower concentrations than what we would normally see for treating the infection, we see that sort of dysfunctional activity in the cancer cells. And so what's happening is you're derailing the mechanism of this highly replicating, over-revved growth cellular function. The antiparasitic drugs put a pin in it, and you see this slowing of cancer growth. So again, why are we using antiparasitic drugs in cancers? because the mechanisms in those living cells in cancer cells, they're over revved, and these antiparasitic drugs just stop them in their tracks. So all of a sudden, all of the other therapies that you're undertaking with cancer, chemotherapy, radiation, and such surgical interventions, you're getting better progression because your drugs are working the same way in those cells. Because those cells are abnormal to your body, this is how it almost targets them. It's really, really elegant, interesting science when you stand back and go mechanistically, not what the drug was approved for, what is it indicated for. And I don't want to kind of go too far and get us into this sort of idea that drugs are bad. What I'm saying is we don't fully understand all the mechanisms at first, and then once we sort of discover we can use them a little bit more differently. For example, we see this new drug called mebendazole. This is getting a lot of discussion around it, and fenbendazole, there's new papers coming up about it. So these antiparasitic drugs are getting a new life in healthcare. And we see this across so many drugs. For example, when we were talking about, and again, a lot of people get nervous about this drug, ketamine. It was essentially a pain drug. Now it's turned into an antidepressant drug. Better understanding of mechanism. Dennison, this is one of my favorite drugs. Everyone thinks, oh, it's a it's for cough and colds, and we use it as an expectorant. We're seeing this being used in patients because of mitochondrial function as well as NMDA receptor activity. So we can actually start using this in different fashions for both pain as well as fibromyalgia, and then starting to use it in patients with depression. So very, very cool with our better understanding of the function and the technology of sharing. This is where compounding is really coming alive, is using these drugs in unique fashion for a larger group of patients to help assist all the other standards of care. So we're getting better.
No, and you're right. The requests we're getting for mebendazole and fenbendazole to mix it with other antiparasitic drugs, we can talk about those that came out during this health crisis that we had in the 2020 era, combining those to work on these conditions. And it's finding and repurposing these drugs at certain doses to see benefit. I mean, you understand that as a pharmacist, and I think that's what puts pharmacy at a really unique position. We understand health systems, biology, biochemistry, but we also understand the drugs and how they work, the receptor actions, the signaling, and all that. And I think that's really what puts pharmacists at a unique crossword in terms of being able to kind of be at the middle to kind of help look through all the fuzz and kind of parse through and look at what benefit is. So we're getting a lot of questions about those too. And talking about drugs that were originally developed for something and then found out for something else, let's talk GLP-1s for a minute.
Oh, man.
Look at that drug. That drug was a diabetes drug. And then, oh my gosh, by the side effect, you can lose 20% of your body weight. So let's turn these into weight loss drugs. And now look at what that industry did. So much that Big Pharma couldn't keep up with production and compounders were able to make this drug. But now all of a sudden, our ability as compounders, because the drugs are off the FDA shortage list, we really can't compound them, which may limit people's ability to get these drugs through compounding pharmacies or a little more affordable. What are some of the things that you kind of talk about in terms of weight loss beyond GLP-1s that may be beneficial for people to understand?
So I get to talk about it, but I'm not the one who's discovered this. And I have to be really clear about this. Let's go back to the makers of some of these GLP-1s and this combination GLP-1s and GIPs. Alzheimer's, dementia research. And they're looking at neurodegeneration effects with GLP-1s and whether or not we're able to modulate that and prevent. That is a massive discussion. Number two, are you ready for this one? GLP-1s in microdosing are immunomodulatory and anti-inflammatory in nature. And so that was one where people just kind of turned around and went, what? We're actually seeing people, there's a number of people out there in the functional medicine world that are already talking about this as health span increasing. So using them in microdosing levels. So at 1/10 of what we would use for diabetes or weight loss management, the dosing. And the one that, Steve, we've talked about some really unique cases, and this is going to blow your mind. There's actually a discussion about GLP-1s used for chronic pain, because we take away the driver of the inflammation. All of a sudden, we're setting down some of that microglial activity. So chronic pain use for GLP-1s, which is a new investigation arm. And if you've never heard this, you can look back at this podcast in probably 3 to 5 years and be like, that's where those drugs are coming from. back in the early 2000s when we're talking about Remicade for Crohn's, that was it. Crohn's. That was all we were using these biologics for. Now we're using biologics for things like asthma, migraine, and bone loss. Now we're getting into GLP-1s, and it's all about diabetes and weight management. But we are going to see this really rapid shift into all of these other functionality, but mainly this immunomodulatory response. Again, not suppression. And we're going to see this sort of health span increase. At some point or another, they're going to have this conversation about, well, which GLP-1 are you on and how is it working for you and what was your major concern? But I get excited because the science of these are just so unique. The problem with GLP-1s, they're so poorly absorbed orally. And I get to say that's because I've talked about this for the last 2 years, but Novo Nordisk applied for a patent within the last couple of days for a 50 milligram tablet because they want to be able to push the dose because the absorption is so poor orally. But we have other methods of administration. Buccal and sublingual is significantly increased. And so there's a lot of information that's being generated there. We actually have, we understand that there's other companies that are looking at delivery of GLP-1s and they're looking at non-oral administration. And so wafers and films and buccal administration, because they understand that that's probably one of the best ways to get in it if you want to avoid the needles. So there you go.
That's awesome. Yeah, these drugs aren't going anywhere. You know as well as me, there are hundreds of them in the pipeline, and it's just going to be a normal part of conversation, I think, for us as pharmacists, and especially us in the wellness space about what these drugs can do. And if you want more information about sublingual forms of semaglutide specifically, those are things you can talk to us about Magnolia Pharmacy. We have unique bases and deliveries like Sebastian just mentioned that allow for the the sublingual absorption to bypass the gut and get the drugs in the system. And we can kind of replicate or kind of look at some of the benefits of like the microdosing aspects of these, but that's a great discussion.
Yeah. The crazy thing is, and I, again, dork, let me be clear. We know that with an unhealthy gut microbiome, which unfortunately people who are obese and morbidly obese have, we see less than 0.5% absorption in the oral route, and up to 1% is the maximum we've ever seen in a healthy individual orally. But we can see anywhere from 10 to 20 times increase in absorption through the buccal and sublingual space. So very, very, very good. And so fractions of the drug, decrease cost.
Very cool. That's a great option. So just kind of as a wrap up, I want to talk about what are some of the things. So we've talked about inflammation and how it drives all disease. What are some of the other things you're seeing right now in your world, or ask about things that are repurposed? They could be prescription drugs. They even could be over-the-counter medications that are being repurposed to help reduce inflammation and help expand lifespan and improve wellness. What are those big things you're kind of seeing right now?
So the biggest one that people are finally twigging, and I've talked about this one forever, but vitamin D, everyone realizes the importance of vitamin D supplementation. Melatonin is a really interesting one because everyone thinks, oh, that's just for sleep. Well, you have a good restorative sleep and then you're going to feel better the next day. But there's literature on melatonin being an anti-inflammatory with respect to the CNS and the microglia. So melatonin is starting to be used as a immunomodulatory anti-inflammatory response, not a suppressant. Oxytocin, there's a discussion there where we're starting to see that. And finally, this is where it's kind of comes back. Ketamine is now being looked at as having some of those effects in the TLRs as well. So those are the receptors that we think about naltrexone. And then we're starting to see more molecules where they're starting to extend, and everyone's looking, well, what is the effect on the immune system? That's the primary question that they're now asking when they're looking at the development of these drugs or these repurposed drugs. Well, how does it work? And if they can figure out that it's got a positive impact on immune system function, either activation for natural killer cells to clear the body of pathogens, or an immunomodulatory, bring that dysfunction under control. Things like methylene blue, they're actually there for a mitochondrial effect, but you get this decrease, or you get this better mitochondrial effect, and then all of a sudden we see the immune system working more efficiently. So we're trying to look at a balancing act, and what we want to see is patients who have a really good harmony in their immune system. Not too much of one thing, not enough of another. This beautiful harmony. And then we're turning people back into their 22-year-old self where you can wake up and just feel good. And yeah, let's go fight infection and be robust and build muscle and have this quality of life that's normal. So there you go.
So it's like the 50 and 60s of today, we can turn you back in your 20s and 30s like they used to be. So we can kind of reverse aging in that sense. It'd be nice, wouldn't it, with all these things?
When people say that 50 is the new 30, people who are really adhering to this, that's where it's coming from, is the health span, the quality of life, just the fitness level of people who are really embracing some of these discussions. We see them. And you are a perfect example of this. Like you can say I've got 20 years of experience and people are like, how old are you? Like that is what you want to hear. And that's what we're able to assist in this sort of functional compounding world of care, because it's not just about here, take this drug in high doses and good luck. It's more like, let's get your immune system working well. Let's make sure you're sleeping well. Let's make sure your gut is healthy. And all of a sudden these patients go, man, I haven't felt this good in a decade. Yeah, that's what we're trying to do, is bring you back to that good, healthy point.
So, Sebastian, this is a question I ask all my guests. So you've got a vast array of medical knowledge. You've been doing a lot of things through the years. You've come from a family of healthcare providers. So you've been basically bathed in this stuff for years. If you could go back to your childhood and look where back then versus now, what's the one thing you would have changed in your own healthcare journey that you think you've been successful, but on the health side, what's the one thing you would have changed back then that you would have done differently now?
Oh man, you're asking a really good question. Probably the biggest one I would have eliminated soda, so Coca-Cola, Sprite, or those things much earlier. I love my wife. Her name is Jennifer. She actually said one of the hardest things that she's ever done is to stop drinking diet drinks, because diet drinks are inherently bad. They can mess with your microbiome, but the sugars also jack with your glucose control. And all of a sudden you have a higher, and not my wife, but anything more than 2 diet drinks in a day, you actually increase your risk of obesity. More than 4, you increase cardiovascular risk, as well as you will probably be morbidly obese. But even the regular soft drinks, they're just loaded with so much sugar. And now they're getting into like all of the acid imbalance, and they're hard in the gut. So that would be number one, is less sodas when I was younger. So that's number one. And number two, understanding the importance of building healthy muscle mass and ensuring that continues. So I was always like a skinny kid and I was always trying to build muscle, but I always focused on doing more cardiovascular. It's like, I got to keep my lungs and heart healthy. Weight resistance training is a good thing. And so I picked that up when I was about 26. I gained about 15 to 20 pounds in 4 months. And I've been carrying that muscle mass. But that is a really crucial part of the discussion, is you don't have to lose weight. What you need to do is increase your lean muscle mass. And if I can convey that to anyone who's on their weight loss journey, is preserve your healthy, lean muscle mass, which means doing squats, doing something that forces your muscles to work. You'll increase your metabolic rate, but you will also preserve long-term health, because the first place your body goes to when you're sick, it'll go into your muscles. And that is like your lifesaver, is better, dense, healthy, lean muscle mass. So that's it.
That's some great takes. I'm right there with the sodas. I wish I would not drink so much soda when I was growing up, but live and learn. Our bodies are resilient. I don't drink them now, so it functions pretty well. So that's for sure.
Yeah, if you can get rid of those at some point, like drink water, drink fizzy water. Like that's fine. Just ditch the brand name stuff that you can buy in a can that costs you $1. It's just, that stuff there's less water in there than there is sugar. And so you need more water, less sugar in your, what was the comment that I heard? Don't drink your calories.
It's for sure. Sebastian, this has been so awesome. This is exactly what I was hoping for, bringing you as a clinical pharmacist on the podcast so that we could dump a lot of pearls in the audience. I know you're kind of hitting at PCCA, so I feel like if somebody ever just was like, oh my gosh, I've got to talk to Sebastian, he said something I want to know, I guess they can always hit me up and I can track you down, because PCCA protects Sebastian because he is so valuable as far as that goes. But I just really honestly want to say thank you so much for sharing your knowledge. You have been so great.
Thank you for having me. And I actually work on an incredible team. There's 19 others who are way smarter than me. I just have a very loud, gregarious voice. But I work within this network of amazing compounding pharmacists like yourself, Steve. You are one of the top in the country. We've always talked about that, but you give us a really generous position within your team. So thank you.
Thank you. Excellent. Thank you so much. I really appreciate you coming on and hope you have a wonderful day. And to our audience, be well. And like you said, more to come about the truth about how the body works. Have a great day. Take care.